Hi everyone, you're listening to Let's Psyconnect, and this is LT. Today we are gathered here. You can actually watch the video, the conversation that I'm having with awesome guest speakers. It is as part of the Let's Psyconnect and talk about suicide prevention. We have a few episodes already, so please catch up and join the conversation because it's an important topic to talk about, and I don't think it's enough. Like people don't talk enough about suicide prevention. And they talk sometimes about suicide, but not enough conversation is going on around what it is that we can do, what research has shown that is effective, and some information that clinicians should keep in mind and apply when working with any type of client and clients associated with high risk for suicide. So without further ado, let's start the conversation. I have here Allie, Shelby, and Taylor, and they're all graduate students. One more just like me, or a few more, I should say. So Allie Bond, she's the second year of clinical psychology doctoral student, and she is in the Suicide and Emotion Dysregulation lab at the University of Southern Mississippi. She has lots of research interests, just like I do, and her colleagues as well. But some of them include better understanding the ideation to action transmission and firearm safety, which is something that we're going to be talking about today, and in what regards to suicide prevention. She runs the Science Simplified Instagram, follow that, which features visual abstracts created by her and her lab mates. It's funny to say lab mates. We also have Shelby here, Shelby Bandel, and she's a third year doctoral student. She's also part of the laboratory. And her interests include the non-suicidal self-injury, emotion dysregulation, firearms, and the association between sleep and suicide. Let's talk about that. And we have Taylor Rodriguez. She's a third year doctoral student, also at the University of Southern Mississippi. And her primary research interests involve traits. So think about personality, socio-demographic variables, and also she likes to look into preference of clients and therapists as they relate to psychotherapy practices and outcomes. So if you guys want to contribute, say a little bit more about yourself, like what brought you to the lab or how you got into the lab and so on. So a little bit about your journey. Who's going to start?
I guess I can start. So I did my undergrad studies at the University of Wyoming, because that's where I'm from originally. And to be honest, how I got into the field of suicidology was I just needed to join a research lab because I knew I wanted to get a PhD in clinical psychology and that research was important. And so I attended a psych meeting that talked about different labs that had openings and just kind of like picked one that sounded interesting. That was called like the stress and mood lab, because at that point I thought that like looking into like depression and stuff would be really interesting. And then I actually got into the lab, and it was run by Dr. Carolyn Pepper, and they were doing a lot of non-suicidal self-injury research, and I'd never really heard about non-suicidal self-injury. And so that's kind of how I got into the field. And then for my master's degree, I worked with Dr. Amy Brausch at Western Kentucky University, and she also does non-suicidal self-injury work, but does a little bit more suicide research as well. And so that kind of continued to push me. And then when looking for programs, I was just really interested in programs that would continue to allow me to research suicide. And I was particularly interested in working with Mike and doing firearms research, coming from Wyoming, having a strong background in like firearms upbringing and stuff. So that kind of led me to where I am today.
Thank you for sharing it. I just love how oftentimes our paths don't necessarily have the goal that is so clear, and then we go like this, eventually we get there and we discover new passions, and which is great because now we can talk more about it.
Yeah, I think for me, so I don't necessarily identify as a suicidologist per se. I did a terminal master's program before I joined this doctoral program. And in there I started doing some therapy research, specifically around like what different factors might impact like trainee therapists' abilities and things like that in the therapy room and outcomes and stuff like that. So I got really interested in things that might impact people's journeys in psychotherapy. And so when I was looking for programs, I was specifically looking for someone that had some interest in that area. And I was also had kind of an interest in what psychotherapy would look like with more high risk clients. And so that's how I got kind of more connected with Dr. Mike Anestis's lab and some of the other people at USM that were looking specifically with, or specifically at suicide and individuals with high risk and stuff like that. So I'm a lot more interested in like the aspect of once they come into therapy, what kind of things can we do? What's going to impact their even willingness to come to therapy and things like that. And so that's kind of like, I guess, my angle in all of this. So that's, yeah, I guess where I'm at.
Okay, thank you. And Allie?
Yeah, it's funny because obviously Shelby and I have known each other for a little bit, but I didn't realize how similar our ways of getting into this field were. I also was like, I have to join a research lab. And I wanted to do trauma research, and they didn't have a trauma research lab at Catholic University where I went. So I joined Dr. David Job's suicide prevention lab, and then was like very interested in just the complexity of suicide research and kind of stayed with it. So again, like stumbled upon this like field that we've stayed in. And after that, I went to work for Dr. Marjan Holloway at the Uniformed Services University. So did a lot of research with the military and suicide prevention. And that kind of was one of the reasons I was interested in working with Mike as well. He had some grants working with the military, but then also kind of lets us dive into our own research interests. Like we all have a lot of overlap, but very different interests. So it's nice to be in a lab with people who are interested like in sleep research, because I have no knowledge of that. So Shelby can teach me a lot of that.
That's great. And I'm so grateful that I have the chance to psyconnect with you guys and learn a little bit about the work that you guys have seen, have done, and have read about, right? So that I can be informed and our listeners and viewers can be informed as well. So one of the things that I am interested in talking about is a little bit about the theories. And so what can you guys share with our listeners and viewers about the theories behind that?
Yeah, I can start, and then we can just kind of maybe like pass it around, because I think this is something we all have been interested in. One of the main, there's really two main theories of suicide that we, reference a lot in our lab. And one of them is Dr. Thomas Joyner. He's at Florida State. He has the interpersonal theory of suicide. And if you think of like three circles and they have some overlap between them, he says, there's thwarted belongingness and perceived burdensomeness. And you really need both of these to have a desire for suicide. But this final piece is the acquired capability. So the ability to kind of overcome our natural instincts of self-preservation and inflict harm on ourselves. And when all of those converge, so the perceived burdensomeness, thwarted belongingness, and acquired capability, that's when we see suicide deaths or lethal or near lethal attempts as well.
Oh, to be honest, I don't think in school they ever talked about this theory, or the other ones that I know you guys are gonna contribute and add to this conversation. So I'm like, this totally makes sense. I should definitely learn more about it. So go ahead.
Yeah, and something that I think is really helpful about that theory is it's like very broken down into like very easy to understand components, which I think is a really big value to it. It's like there's these things, and this is like that really high risk zone. It kind of gets at what differentiates people that have suicidal ideation and people that actually attempt suicide, which is like a huge question in our field that we're like really as a field struggling to answer and figure out. And so I think like that's a really nice value in that theory. Also, there's for people that are interested, Thomas Joyner wrote a book that is all about that theory, and it's like a very I think like easy to digest book that explains his theory and kind of how he came up with it. I think it's just called the interpersonal psychological theory of suicide.
I think,
If it's not, we'll figure it out. I'll add it, comments later. That's
on Amazon somewhere, yeah.
Yeah, but it's Joyner's theory. Okay, and then the three keywords are burdensomeness, belongingness, and capability. Okay. So it makes it easier for us to look into a little bit more. Because the one we often associate suicide with depression, and whether or not somebody's depressive or everyone who's depressed, they are thinking about suicide or and whatnot. And so looking at that suicidality, that component, so the suicide behavior ideation from that perspective of like feeling burdensome or belongingness, and where you are in that, I guess, possible scale, like you feeling like you belong or don't belong, and capability if you can or cannot. And so I'm thinking about the idea of resources where that would fall under, I guess, maybe under the capability component. I don't know if you guys can share a little bit more about the theory then.
Yeah, I think, kind of going off what you said, capability is this like very broad concept, right? Like we don't necessarily know what gives people capability. So we've looked at it in some ways in the field of like military, because we know military has this experience. They go to combat, they have firearm training. Like, does that make them more capable? And we believe it does, but Klonsky and May, and Dr. Klonsky is at the University of British Columbia, I believe. He has a theory that kind of builds off of Dr. Joyners' theory called the 3-step theory. And it talks about capability in 3 domains. It's like practical, dispositional, and acquired. And I know one of the things that we've talked about a little bit in our lab is like the practical capability piece, like owning firearms. We do a lot of research on how owning firearms could potentially make someone more capable, experience with firearms. That's kind of the practical component. Acquired is similar to what Dr. Joyners was, and dispositional is like your genetic predisposition almost to capability. So he breaks it down even further, which I think, and you guys can definitely speak more to this, like as like a clinician, being able then to address 3 different components is a lot easier than looking at just like capability in general.
Yeah, because when you're doing a suicide prevention plan or even an assessment, right, you're looking into, I guess, this component, not necessarily the genetic part of it. I think you do ask about history, and so I guess you're looking into it, but more of a historical, anyways, so that can, because people in your family have committed or attempted suicide, then you're also more likely than those who don't have a family history. So yeah, I don't think we necessarily put a lot of thought into it, and I don't know, but like, especially when you said like the veterans or the military personnel, you don't necessarily see the family history. You see because of the training and then learning how to use firearms and having access to firearms.
Yeah, I think you bring up a good point about like trying to be aware of how we're assessing suicide risk and how we can apply these theories into practice. I think, so like for our clinic, for instance, our training clinic, we have a suicide risk assessment that's based off of Joyners' theory. And so we're asking questions about these different areas and trying to get at their risk factors, how much intent is there, do they have access to means and things like that. And so that way we're getting a full picture of not only is this person thinking of suicide, but do they have these other factors that can make them more at risk for actually attempting or dying by suicide. So I think that's really something important for clinicians to consider, kind of adapting into their own practices and things like that as well.
Yes, yeah.
And
you add something?
Yeah, I was just gonna say, going off of that, I've talked to like clinicians and stuff before that, bringing up firearms is like can be a very stressful thing to do in session, and it's even more anxiety inducing when you know your client's suicidal, right? And so I've talked to some clinicians that actually recommend doing it ahead of time, like in your intake, asking like, do you have access to firearms in the home? And that way, when your client comes in and is feeling, suicidal and has suicidal intent and all of that, you're not in a position where you're like trying to figure out, well, like adding this extra layer of stress about asking, do they have firearms? You already know. And it could be something very simple as like, so I know when we did intake, you said that you have XYZ firearms in the home. And then figuring out from there what the best plan of action is to kind of keep that person safe. And I think that's something that's like really useful for clinicians, because when a client's suicidal, it's already a very stressful time, and adding an additional stress factor of that being the first time you ask them about firearms is like a lot of stress in that moment. So trying to kind of get some of that out the way ahead of time, I think, is a really useful suggestion.
Yes, definitely. I believe the way that I've been trained, and hopefully other clinicians too, or future clinicians, is to add those questions to the intake piece for sure. And it was the setting where I'm at, and the other settings that I've been, we also add questions to assess for suicide risk during any session anyways. And that in some levels can be a little bit easier because you have built or you're building a rapport with the client. So the uncomfortableness, sort of like fades away because you have that relationship with the client. But I know it's still difficult, especially when they say it is yes, and you've never worked through a crisis situation in your life, so then the stress levels go even higher. For us as students, I think there's always a little bit of anxiety, and not to say that experienced professionals or clinicians don't have any type of anxiety when working through a crisis. I'm saying that for students, like, I don't know what I'm doing, like, and then eventually the learning curve settles in, and I'm like, okay, now I feel more comfortable working through a crisis. I can do this. But I think having the knowledge of the theories as well as the steps to go through in a crisis situation, like you repeat to yourself, what am I supposed to do? Okay, A, B, C, D, and the policy, whatever like setting where you're at, if it's a VA or the hospital or community center, they all have policies too. So like understanding, being familiar with the policies and practice, and your supervisor should be available to help you through a situation, I suppose. In the ideal world, that's what they're supposed to do. But always ask. And I know I went through a training recently where they did talk about like clinicians who will assess for suicide ideation and intent and planning with the frequency that is relatable to how comfortable they are talking about it. And that varies with how comfortable they are talking about firearms. Because if it's the person that say, yes, I own a firearm, and then like, okay, what do I ask now? What do I do? I'm not comfortable. I don't believe in guns or whatever, like their belief sometimes gets in the way of assessing and proceeding with the conversation. So.
And I think too, like, what Shelby was saying of adding it in earlier, like the more we ask about firearms, just like the more we ask about suicide, the more comfortable we become. And I think like it also falls on the clinician to educate themselves a little bit about like what are safe ways to store firearms and how do those potentially reduce suicide risk. Not that we have to be experts, if we're not firearm owners, like we don't need to pretend that we are, but having some tools in our back pocket to fall back on, opposed to being like, oh no, we have to, do X, Y, and Z, and maybe there's some steps before we get there.
Mm-hmm. Yeah. And what are some of the things to address in firearm safety? What is it that research and your work has shown that it's important to address in a conversation of pertaining to firearm safety?
So I think a big thing that we always say in our lab is that owning a firearm does not make someone suicidal, right? But if you have access to a firearm and you experience suicidality, you're a lot more at risk to die. And so that's where the concern comes from. And I think that in terms of addressing firearm safety in those moments, it varies by individual and what they're comfortable with, and kind of also as a clinician, what you're comfortable with. So firearm safety can come in a variety of factors. It can be, if they have someone they can take their firearms to that they trust, and they feel comfortable like telling them that they need to take them away for a minute. I think that's like the ideal situation, right? Is that we completely remove them from that person's access. But people aren't always comfortable with that. They don't always have someone that they feel like they can have store their firearms. They don't always feel comfortable telling someone that they shouldn't have their firearms at that moment. There's like a lot of concerns that come up with that sometimes. So there's other things like you can do like cable locks, and then like, can someone else hold the key to the cable lock, right? So then it's not the whole firearm is going away, but it's just like you put some kind of cable lock or trigger lock on it, and then you don't have the key, so you can't use the firearm in those instances. Or like ammunition. Can you like remove all the ammunition from your house? And then like, you know, you don't have that aspect of it. For some people, it's like putting their coping card where their firearm is, so that if they like were to that point, they have to like look at their coping card or pictures of loved ones on top of their firearm. So it's like such a broad area of things that can be done. It's just a matter of like in that moment, what is the best choice for the clinician, right? Because like we want to make sure we're keeping our clients safe, and so we want to make sure we're taking all of the steps that we should, but also what's realistic with the client. And I think a lot of that learning came from working on Dr. Mike Anestis's grant that was a randomized control trial looking at like mean safety with National Guard members. And that's where a lot of, I think, my learning about what kind of openness people are going to have to different options came from having so many conversations with individuals in the National Guard. And you see just a very wide range of what people would be like open to doing versus less open to doing.
Yeah. And so it's important not for the clinician to think like, okay, just give your firearm away, or because that could be an option. But if the clinician is not familiar with all other options, it's going to be really hard to have that conversation with the patient or the client in front of us, because we won't be able to problem solve or get creative or brainstorm with the patient either. Yeah.
I think also building off what Shelby said, I totally agree. I think all about like whatever barriers you can put in the way. Just want to put a plug in. There's a few states, including Mississippi. One of our lab mates, Sam, helped lead an initiative. It's called like the Mississippi Map Project. Colorado has one, and Maryland, that are places where people can take their firearms to store them temporarily. So we're not saying forever, but you don't have a loved one that you could give it to, or, you know, if your grandkids are coming over, really whatever it is, if it's suicide risk, if it's you're moving, if you have kids coming over, you can bring your firearms to these locations and store them there temporarily. That I think is an awesome tool. It also helps us get around some state laws, because in Mississippi, it's easy to transfer firearms from one person to another. It's not as easy, let's say, like in like New Jersey. So having other options for people is really great.
Yeah, I learned that when I talked to Sam last time. So that was a great piece of information for sure. And in recent training, I also learned that you can call the police station and some gun stores to see if they have that capability or if they know of an option. So that's something to keep in the, I guess, the toolbox as well and explore. And social workers too. I don't know if sometimes you work with other team members, you know, it's like, I don't know if it's a private practice, it's very different, because I know sometimes it's just you as a provider, but sometimes when you connect with social workers and other people in the community, they know more about that. They have more resources. And so it's just having that person one call away, like, we talked about this, can you provide me some information on it or whatever, you know, so that is helpful too. There's one more thing that I want to talk about, and we again, well, I talked to your colleagues in the other episode, but I think it's important to put more emphasis on the groups that are higher risk for attempting or committing suicide, either by firearms or other means and ways, and talk about stigma. So let's address that.
Yeah, I can start with just kind of the higher risk groups, and I know Taylor might have some more knowledge too on like the stigma piece, as well as like seeking services, since that's more her area. But we've done some research on just different groups. There's a lot of groups that are at high risk. So obviously firearm owners, there's, you know, Shelby addressed before, owning a firearm doesn't make you suicidal, but you have then a highly lethal method. We know that veterinarians are a higher risk. They also have access to lethal medications and experience using it. There's a lot of research being done at the University of Auburn on that with Dr. Tracy Whitty. We know individuals who identify as gender diverse or are transgender are also at a higher risk. Those are just some groups that are at higher risk, but I think the stigma within all those groups is a little bit different.
Yeah.
Yeah, and I think, oh, sorry, go ahead.
No, I was just going to say that recently too, there's the association of being a veteran or in the military and having access to means. And before in the past, there used to be association between males, right, or identified as men, and committing or attempting suicide. But we know now that more women or those identified as women, they are also attempting suicide and by use of firearms, whereas before it used to be maybe pills or something else, and then so they are using firearms. So keep that in mind as well.
And I think to your piece about stigma, like I think it's really important for all the groups that we're talking about, right? We know that like over time, mental health stigma in general has declined, right? And which is a great trend, but we don't see as significant as a trend when it comes to stigma regarding suicide. So it's even though there might be a little bit more openness to talk about mental health and things like that, sometimes that piece about suicide can still be really hard for people to bring up, especially if they go to treatment and they think that they might be hospitalized for expressing any thoughts or things like that. And so I think that one thing for people that are coming to treatment is to be open about your conversations, explaining to people about your role when it comes to suicide assessment, what kinds of things could happen at different levels of suicide risk, and kind of having a really open conversation so that that client is kind of aware of what types of things are going on. And I think that can reduce some fear when it comes to what would happen if I do tell my clinician these things. Because I think a lot of stigma can come from that, even for people that are already coming into treatment. So I think that would be like one piece to kind of think about for sure.
And I know that some clinics, they offer or they have professionals that follow up with patients identified to be a risk. Sometimes it's called suicide prevention coordinators. And so if your clinic, right, or hospital, whatever place where you work, they offer that, I think it's a great piece too, because then that person, like, again, this person wasn't institutionalized, right? There was concern, but it wasn't taken to hospital. It didn't have to be Baker Act or whatever term it is that your state utilizes anyways. But there's still a professional following up closely and available to talk to that person, right, and explaining that piece. Hey, I'm going to connect you with somebody else. I think it's also important to, otherwise they're get a call, like, who's calling me? Why are you calling me?
Yeah, I think another part of that too is like, I think you talked to Kayla a little bit about hotlines, but also like making sure that clients understand how hotlines work, because some clients think if they call a hotline, they're immediately like going to have the police called and like show up at their door. And like, so also like explaining to them that like these services are like really there to help. That's like not how this works most of the time. And just, I think like it's helpful for clients to understand like what the thresholds are for different things to happen. That way they feel more comfortable. Because I think all too often clients come in thinking if they express any level of suicidality that it's going to be this huge fuss and they're going to be hospitalized against their will. And like, we know that hospitalization for suicide is usually not super helpful. And so like, we try to avoid that. And I think that being honest and open with clients about how those thresholds kind of work is a really helpful way to to help them feel more comfortable a lot of the time in disclosing suicide.
Even when you're doing a suicide prevention plan, or again, however you call it, at a clinic or based on your training, to have that piece, that card of information with the client, right, or for the client, so they can take home. That conversation can really help the client understand, one, why you're doing, the value of it, and where to keep it. Otherwise, like, why are you asking all those questions? I don't know the answer. I don't know what triggers are. I don't know what risk factors are. What are you talking about? So rather than just like trying to check something off your list, to make sure that you're using it in a way that is therapeutic.
And I think
again, it's hard.
Right. I think that at some level, I've found anyways that clients don't have a lot of people to talk to about these things, right? And so like, because there is a lot of stigma and there is a lot of shame when it comes to these things, it can be really really powerful for a clinician to talk openly about suicide and what steps can we take and where are you at right now, things like that, and asking things directly and trying to be as, you know, open with your client as possible can be really important for not only them to be safe, but also for your therapeutic relationship and for the process that you're making, things like that too. So
yeah, and you added an important piece of fighting stigma here, right? Which is they don't have people to talk to, and so we as professionals, right? Allie's facilitating this Instagram page, which is taking to raise awareness, less psychonnected taking. So we as professionals, we're trying to do it. We're reaching as many people as we can at this time, and we continue to hope that more people will have access to information. And we also know that like just like researchers talk to researchers or professionals who read research, right? I'm not thinking of like a possible client that I'm like, what does research show about this? It's unlikely. and so how do we make it accessible for people or making it okay? So we're talking about changes in culture, which again, we continue to promote so that more and more people can talk about how they feel and some of the thoughts they have. Because it's unlikely that somebody's gonna look checking with their friend and like, how you feeling? Are you feeling suicidal today? You know, it's unlikely. So what are some of the topics or some ways that we can raise awareness? Like, do you guys have any thoughts about that?
I think, you know, just echoing kind of what you said about like disseminating what we know as much as possible. Like, you know, what you guys are doing with the podcast, just like getting information out there so that if people do look it up, they have like research-based information, I think is really important. I think that kind of covers a variety of things. So from research to, I know Taylor's done some stuff about other alternatives to calling 911, just getting as many numbers and information out into the community as possible is one way that we can just, if people read the word suicide enough and read research about it, I think there's going to become more comfortable talking about it. That's my hope, at least.
Yes, yeah, and I hope that, for instance, if you have lost someone to suicide or someone who, or you know somebody who has committed, to have this space to talk to someone about it, to talk, hey guys, it's family dinner, we gotta talk about this, you know, and let's talk about mental health, let's talk about like what this means and what it doesn't mean, and so on and so forth. So that we'll be raising children in different ways. We're also promoting changes within adults.
Yeah.
And I think things like that can really address the piece of getting people into treatment more often too, right? Because that's a whole nother level of stigma and difficulty, is like people might not want to come to treatment. They might not be as willing to seek help and things like that too. And so by putting things into the community, information into the community, and promoting this kind of what you're saying about like these conversations that are more like between family members, between peers, between other people that aren't clinicians to client, is really important for addressing some of that. And I think by being able to post things and share things online and using things like Psyconnect, you know, I think it can really add a lot to that conversation.
Yes, and let's not get discouraged by any changes or detours that we might face, you know, on the way, and pushbacks. There's one more thing actually that we thought that would be important to share with our listeners and viewers here, is that we are in a time in our lives where we are offering services that is more like via virtual, like online, than ever before. I know telehealth has been around for a while, but it wasn't widespread as it is right now. And I know that some people, some professional psychologists are actually allowed to offer services across borders, right? And so you might be in one country, let's say in South America, and then offering services in the US or in Europe or whatnot, right? But I think regardless of that, whatever country or code right, allows you to do or not, I think there's one thing that comes across in Joyners when it comes to telehealth and suicide prevention. And what is it? Let's talk about that.
Yeah. So I think telehealth is obviously different for suicide prevention because, you know, in a traditional setting, you're in your room in a room with the client, and if the client is like at an acute extreme risk for suicide, like you have access to them and ways to keep them safe. But this is different because we're no longer in the room with our client. So what do we do? I think something that as we transition to telehealth, I thought was very interesting, but really useful is always getting client location. Which like, this is something I never really thought about before because we hadn't done telehealth prior to like being forced to transition, right? But knowing where your client is and how important that is if something does go, that direction, and also explaining to your clients that that's why you are getting that information, being like open that like, where are you at today? And, making sure they know that that's a way so that you can keep them safe in case something comes up. And then I know our clinic also does we have a sheet that we do with new clients that gets at like, what's their nearest hospital? What's their nearest police station? Goes over like local mental health crisis
response teams.
Yes, thank you.
Yes.
Crisis response, like all of that, so that you also have that in one document. So you know where they are, and you have also all of these resources in case something goes that way. I'm sure there's more that I'm missing.
I think those are big. And when you have that conversation, giving them those resources so that they have them on hand, you have them on hand, we kind of have a general understanding of different steps to be taken, things like that is really good. And then just getting used to like asking about suicide risk every time you see them, and kind of seeing where they're at, making sure they still have their resources, and that asking them how they feel about using those resources and stuff like that, and just kind of trying to keep the conversation going can be important. I think especially now through telehealth.
Yes. Yeah. Go ahead, Allie.
And I think this is like, I totally agree with everything they've said. And I think our clinics try to give us some like resources to feel comfortable and have some agreements with our clients, because it's odd for us, but it's also odd for the clients who are used to coming in. And I think also just like using technology, like now that it's like in our face all the time, how we connect with people, things like there's like a virtual hope box app, like really getting our clients to use, like if their phone's always on them, if we're talking to them on their phone or on their computer, using that to our advantage. So using that, or having them take pictures of their coping cards, or like, what can we do so that it's, these tools are always with them.
Yeah.
I think building off of that, always having your clients put the hotline numbers in their phone, like during intake. Like these are just numbers that I think everyone should have in their phone. Maybe it's never something for you, but then you have it for a friend. Like that way, people usually have their phone on them and they have access to that, because most people aren't going to memorize the hotline numbers, right? That's like not something we can expect from clients. So just having them like put that in their phone so that you kind of get ahead of things if things come up in the future.
Exactly. And then again, if you are providing services outside of your country, yes, you add in a piece, to your workload, which is trying to figure out that kind of information, like crisis lines, local hospitals. So as soon as you gather, let's say, the address of somebody who might be a possible client of yours, then try to become informed of the resources available in that location, right? You chose to have that client, so you're also choosing to be informed so that you can be the best provider for that client as well.
Yeah. And
if you work within an agency or community center or whatever, it's likely that that kind of information is going to be provided to you. So that's an advantage when you work with others. There's a group of people already focused on that and trying to figure it out, especially that when you're providing services to folks in rural areas.
Yeah.
So the main hospital you think like is the main hospital for you, let's say, because you wouldn't go anywhere else, but somebody lives like 45, 50 miles away from that hospital. Maybe there's a local clinic where they can go to, or the other next hospital to them is not your hospital. So like trying to familiarize yourself with the areas where the clients are located at. One thing is that it's not often talked about, it's new to me too, is to get license plates and then use, let's say, street road, because sometimes they are in a car. They are in a parking lot, or they just pulled over in a highway. So you want to know where they're at. They might not be in their house. So you want to know their license plate and some type of point of reference so they can share with, let's say, a crisis person or whoever is going to respond to the situation.
Yeah. And I think kind of going off what you said of like learning resources in the area, I think telehealth has had people, connect and be really creative and, using that to our advantage so we don't have to kind of reinvent the wheel. I know Dr. Keeney Law, who's actually an alumni of our lab, is at Seattle Pacific and created, with the help of others, this like giant document about crisis stabilization units and response teams throughout the country. So kind of instead of having to be like, oh, my client, is in Mississippi, I have to look up all these places, like really like finding the resources that already exist, lightens the load on us. And also we know it's reputable and we know other practicing psychologists have been, are the ones providing that information.
Mm-hmm.
Yes, I think there's going to be a lot more to learn as we continue to navigate this telehealth world. There are telehealth guidelines, so look them up to be familiar with them. If you are going to take EPPP, you're more likely than not to have to be familiar with them. So, so there's that as well. Well, guys, ladies, I shouldn't say guys, sorry. This has been wonderful. I'm so glad again that I got to Psyconnect with you all and share and brainstorm and talk about suicide prevention and be more research informed. Is there anything else you ladies want to share with me and with others today, and also how else can they reach out to you or be more informed, for lack of a better word, and keep up with the work that the lab puts out there?
Well, I was leaving it to Allie, and now
Allie, you're in the spot.
I can respond. Sure. I don't think I don't have anything else. I think we covered a lot of good information. I think just like continuing to kind of track articles that are coming out about COVID and suicide risk. There is one coming out from our lab soon that's going to be very interesting. So we will be creating visual abstracts, and I think Taylor's actually going to be working on it to kind of get it out there. So finding the current research is important, and we're going to try to keep pushing it out that way. We all have professional Twitters, so you can definitely follow us. And we have a lab page as well, and our lab page has information about the MAP project that we mentioned and that Sam had mentioned, as well as we're going to try to get our visual abstracts on there. My Twitter handle, I believe, is AllieBond12. I think I can make sure of that.
You can share that with me. I'll add it to the episode description on like the major podcast platforms, as well as on Instagram. Whenever they go to our my IGTV, a part of the page, they will be able to see the description, and I'll add your Twitter handles as well. I no longer have Twitter. I'm focused on Instagram, but I also have Let's Psyconnect also has a page on Facebook and YouTube as well. So
yeah, I'll say definitely reach out if anyone has any questions, if there's any interest in collaborating on things, getting your research out there. We're definitely wanting to spread a lot of information the best way we can, and visual abstracts are a good way to do that and stuff. So we're happy to highlight other people's research too on our pages. So definitely reach out. We appreciate you having us on Let's Psyconnect. It's been really good and a good way to get information out there.
Awesome. And we'll certainly stay connected. And if you guys are good, then we can say our goodbyes.
Yeah, sounds good. Thank you.
Yeah, thank you so much.